Hello, everybody, and welcome back to another episode of Hybrid Healing Hour. Today, we are going to be talking about ketamine, and specifically ketamine-assisted psychotherapy for pain, depression, PTSD, and addiction. We have a very knowledgeable and special guest with us, Dr. Michelle Weiner. We'd love for you to go ahead and introduce yourself and tell everybody a little bit about your background and how you got to where you are today.
Thank you for having me. So I'm an interventional pain management physician. My specialty is actually physical medicine and rehabilitation. And after being in private practice for many years, I was frustrated with the opioids, and I started to use cannabis as a substitute for opioids, and that led me into the plant medicine world. And I realized that cannabis had the ability to alter people's consciousness, and I also realized that opioids were not allowing people to enjoy natural pleasures in life because opioids essentially are similar to our endorphins. So I started to understand the cross-section of chronic pain and mental health and how a lot of it is related to unprocessed trauma and chronic stress. And I started to look for other options for my patients. And so I was trained in ketamine infusions as a pain fellow at University of Miami. However, I started to learn a lot from my psychiatry friends about how to integrate ketamine-assisted psychotherapy in the sense that we're taking a look at the whole person and not just the specific condition or the specific symptom that they have. And so I now really take an interdisciplinary approach to treating chronic pain and mental health. My practice is called neuropain health, and the concept is really the fact that people are living and they're not really understanding why they feel that they're in a constant state of fight or flight. And pain really can be reprocessed. And a lot of it has to do with our predictive models and things that have happened to us in the past. And so what I encourage patients to do is optimize their lifestyle while giving them a catalyst to make change. And so now I'm really using cannabis and ketamine-assisted psychotherapy to treat chronic pain and mental health.
It's fascinating.
Yeah, before we did this podcast, I did a little bit of research because I didn't really know a lot about the history of ketamine and how long it's been around. It's actually been around for 60 years. That's quite a long time. It was first synthesized in 1962 by Professor of Chemistry Calvin Stevens, and I think that it was first tested on human prisoners, right, in 1964. It then, over time, evolved into being a street drug, and it got a bad reputation. And then in the 2000s, it became a controlled substance. And now research has been done since 2000, showing that it's actually very potent as treatment for depression.
Yeah, I think the other part that's important to mention is that it was used in the Vietnam War, mainly because they used to use morphine to help patients to stop their pain from a specific trauma. They started using ketamine, and they realized that the patient was able to be hemodynamically stable. And so there wasn't any respiratory suppression with ketamine. Their pain was relieved, and at the same time, they didn't have the same emotional charge from the trauma because ketamine is a dissociative anesthetic, so it takes away pain but also allows the person to leave their body, so to speak, for a period of time. So it became well known for pain management during the Vietnam War, and then the research has also shown not just for pain but as an acute for suicidality. It's a very rapid antidepressant.
So one of the words that we hear used a lot when we talk about ketamine is dissociation. And so for people who really don't know what that is or have never experienced that, could you explain what is dissociation?
Yeah, it's very difficult to describe until you actually experience it. And most people just describe it as extremely weird. And what that means is that they are almost leaving their body and witnessing what's happening to them. So dissociation is basically where your default mode or your conscious mind is kind of put on hold for a little while so that other parts of the brain can connect and communicate. And in that process, what people really feel is this almost dissolving type of feeling where they're merging with something else, or they're becoming something that they can't separate themselves from. So dissociation is really difficult to describe until you experience it, but it's more of an out-of-body experience where you're almost the observer to yourself. So a lot of people who are very focused on their story. Let's say they have chronic pain and their identity is defined by their pain, or they have past trauma and they're really every day in this loop thinking about their trauma. They're able to kind of take a break and their story or their pain just kind of drifts off because they're not really in their body at the moment. So it's different than a psychedelic or a hallucination or something like that, but dissociation is really described more as like witnessing yourself. And it's an interesting feeling, but it gives people a little bit of relief because they're not in their conscious mind thinking about their trauma or thinking about their depression, or they're not in their body feeling their physical pain.
I have so many questions to follow up with that, but let's start with one so what is the difference then between other psychedelics and ketamine?
So classic psychedelics activate one of our serotonin receptors, which is the 5-HT2A receptor. That receptor is the classic what needs to happen in order to have a hallucination or psychedelic experience. That would include psilocybin mushrooms, LSD, mescaline, DMT, ayahuasca. All of those are classic psychedelics. Ketamine is something completely different in the sense that it's a dissociative anesthetic. It blocks our NMDA receptor, which is a very specific receptor all throughout our brain, but it's blocking a receptor that is responding to glutamate, and glutamate's an excitatory neurotransmitter. So it actually blocks the NMDA receptor on our GABA interneurons. GABA is inhibitory, so it causes a increase in glutamate, and this glutamate surge lasts for about 2 to 3 days. So with ketamine, you have a critical window of period after you do ketamine where there's an increase in glutamate, and that allows for people to feel more motivated to make change, to actually feel positive, to have a different way of looking at things. And so it's really critical to do ketamine in a way that optimizes neuroplasticity, because you're essentially giving them a medicine to create change by creating patterns in the brain. And then this only happens for about 3 days. So usually we do ketamine sessions twice a week for 3 weeks to create this neuroplastic change.
Can you touch on what the neuroplasticity a little bit more and the effects of how ketamine is on that and what it's associated with?
Yeah, so neuroplasticity is just the brain's capacity to change. And honestly, that could be good or bad. You know, addiction technically is neuroplasticity gone wrong. That's someone reinforcing a negative habit. So what we want to do is prepare the patient and optimize their lifestyle so that when we give them ketamine and we do it over a course of a few weeks, we're creating a new neural circuitry in the brain, and that's from a growth factor called brain-derived neurotropic factor. So there's an increase in BDNF, and then that allows for this functional neuroplastic change, which basically means the brain is starting to have a new pattern. And a lot of what I see is people's experiences in past have actually set them up with a lens that is creating their reality, and that reality may not actually be true. And so a lot of what we're doing is trying to understand how much of their trauma is related to developmental trauma or acute trauma or poorly managed chronic stress, and how we can actually help them with a plan going forward so that we're creating positive change within the brain, and then their thoughts, feelings, and behaviors all match.
Wow. There's so much science behind it that I think, growing up in the 80s, I was like, it's a street drug. I didn't think much of it. So talking about the legality of this, since it's not known as quote unquote a street drug anymore so much, what is the legal framework for psychedelics in the United States or in Florida?
So ketamine is a Schedule III drug, which means that it's a completely legal medicine. It's used in the OR. We usually use ketamine in the OR. If you think about it, if you're having surgery done on your body and you give someone ketamine, they physically don't feel the pain and they don't really remember anything about the surgery. So that's really almost looking at it as a dissociative anesthetic. They have no pain and they're not really recalling it. So ketamine is completely legal. It's actually FDA approved for treatment-resistant depression, which means that someone has to try and fail different medications and see therapists prior to being approved for it. But that's only in the intranasal form called Spravato. Ketamine in general is used mainly as an anesthetic, so it is still a Schedule III drug. Schedule 1 drugs would be things like psychedelics, psilocybin, LSD, even cannabis, which means that it's federally illegal, you can't prescribe it, and there's not enough information saying that there's medical utility and it has a high potential for addiction. So all of the classic psychedelics are a Schedule 1 drug, which means they're federally illegal. However, there's many other states that are starting to decriminalize them, which basically means if someone is caught with the substance, there's not really any actionable punishment. In Florida, we don't have that program yet, so every classic psychedelic is still considered illegal. There's many studies going on right now looking at things like MDMA and psilocybin, so hopefully in the future that will change. But there's a whole FDA process that goes along that, we're starting to understand how these can be put into a medical framework based on the fact that there's multiple studies showing, even phase 3 studies, that they may be effective for things like PTSD and depression.
If something is classified as a Schedule 1 drug, can clinical trials still be done?
Yeah. So there's, for example, MAPS, the Multidisciplinary Association of Psychedelic Studies, has done a study using MDMA for PTSD. And MDMA is actually technically not a classic psychedelic because it also increases oxytocin, has that amphetamine part to it. We call it an entactogen or an empathogen. It gives you that heart-opening type of feeling. So they've researched MDMA for PTSD. They give us a session of MDMA once a month for 3 months with a lot of preparation and therapy. It's not just a medicine session, and integration. And phase 3 showed that 70% of people didn't even qualify for the diagnosis of PTSD at 1 year post, which is better than most PTSD medications.
That's amazing.
Yeah. So they actually made CPT codes for MDMA that will come out July of 2024. And they think the first patient would be able to get medication early 2025, which would be an FDA-approved medication, no longer a Schedule 1.
Wow.
So who are candidates for this type of therapy?
So the problem with ketamine right now is that it's not covered by insurance in an IV or intramuscular form, only in the intranasal. And so anyone, I would say, who has treatment-resistant depression, which means tried and failed different courses for their treatment of depression, PTSD or chronic pain, more specifically neuropathic or what I call nosoplastic. Nosoplastic is more pain that lives within the nervous system that may not have any objective findings, like things like fibromyalgia or chronic migraines, even chronic fatigue. So more processes of central sensitization. So, anyone really suffering from a trauma or has depression or chronic pain.
And you have seen it work well for addiction as well?
Yeah. So, I am really in the harm reduction field, right? That's how I really started trying to use cannabis as a substitute for a lot of different medications. And so I have a lot of patients who have alcohol use disorder or who do have different addictions. And we use ketamine-assisted psychotherapy to get to the root of their pain or the root of their trauma. And so the addiction to me is just really, it's not why the addiction, it's why the pain.
It's a secondary, right?
So usually working with them, we do a full biopsychosocial integration model where we're able to understand all different parts of their life, not just medically what's going on physically in their body, but understanding how they grew up and what their coping skills are, and really looking at their social support and understanding what's happening psychologically in their mind also. So understanding who the person is as a whole and not just individually looking at them like a person with an addiction. So, that's kind of how we really do this process. And then there's different layers to it. Sometimes throughout ketamine, different parts come up. They have a really positive session and, feel really great to make change. And other times some trauma has come up that now we need to work through. So it's not always just, linear positive. It's kind of a little bit of a journey.
Is this considered facilitated treatment? Yeah,
so everything I do is ketamine-assisted psychotherapy. I was trained by Phil Wolfson, who wrote the ketamine papers, and Bessel van der Kolk, who wrote The Body Keeps the Score. And it's really understanding the entire person. And so what we do is during the ketamine, we have a facilitator or the therapist there. So if anything comes up, they're able to discuss that, and we're able to integrate it at the end. So close the session and understand the psychological insight that may come up from the session, and then how to integrate that into their life and make change. Because what I've seen is that ketamine works fast, but may not last long. And that's one of the big issues. And so the durability will change if you properly process the trauma with a therapist or a coach.
Absolutely. So I'm assuming you have a whole team of people in your office?
I do. And honestly, like after all these years of practicing, that's my answer to how to be successful, is really just having a really wonderful team that you can trust, that all have their own skills, and we're all very equal. I have Sherry Kaplan is our head therapist, and then Jessica Stark is our nurse. Anna Margaret as our facilitator. We have different roles for everyone, and everybody is able to support the patient in the way that they see fit for themselves in terms of their skills.
Do you find a difference in efficacy between the intranasal versus the IM or the IV?
Yeah, so the way that the intranasal work, because it's covered by insurance and it's intranasal, this is, and it's also S-ketamine, so it's not a racemic. So ketamine has an SNR enantiomer, and the Spravato is just the S-ketamine. So it's a little bit less potent, but also the intranasal route is very fast-acting, and they have a shorter experience. So, for example, maybe they'll feel the effects for 40 minutes. We can do an IV for 40 minutes, or I can do 2 intramuscular injections that may last 60 or 90 minutes, or I could do an IV infusion that lasts 2 to 3 hours. So with intranasal ketamine, they have to do it twice a week for 4 weeks, and then once a week for a month, and then once a week, and then once every 2 weeks for a month. So there's like 14 sessions over 2.5 months. And again, because ketamine is very fast acting and not long lasting, this is an example of how people need multiple experiences. The problem I find most with Spravato is that the clinicians may not be doing the proper therapy with it, meaning they're just giving the patient the intranasal, and they may not be getting to these higher levels of dissociation, and therefore they need more sessions.
I couldn't agree more with that. I have a few patients on Spravato, and we definitely work towards the therapy aspect as well. I mean, this is just part of the treatment plan. And so you've already gone into like dosing. It seems like it's different. You probably have different protocols for different conditions, I'm assuming.
Right. So with similar to cannabis, it start low and go slow. Usually when it comes to ketamine, a lot of the research talks about 0.5 milligrams per kilogram as a starting dose. If someone is very anxious or someone has a lot of psychedelic experience, that dose would probably change. Usually we get to have about 6 sessions with them. So we're able to start at a certain dose, see how they respond, and then increase by 0.1 to 0.2 milligrams per kilogram every session. I personally like the intramuscular better than the IV because I feel like it's more relational. We're able to be with the patient, sit in the room with them, and then the way that intramuscular works is that all of the medicine gets delivered within 3 to 5 minutes because you're doing basically a shot in the person's arm, right? So when you're doing that injection, they get all the medicine within 3 to 5 minutes. So we usually divide the dose into 2 or 3 shots. And that's because you don't want to give them a huge dose all at once and send them to the moon.
Right.
So like, let's say someone's going to get 60 milligrams in an IV over 60 minutes. We would probably give them 20 milligrams to start intramuscular, see how they do. After 15, 20 minutes, give them another 30. Okay. We kind of divide the dose up like that. And this way they remember the session more. And that's really important because we're bringing them back to speak with the therapist a few days later, and we want to make sure that they understand what happened. If we just are looking at it as a medication and they're not really gaining that insight, then I think it's a lost opportunity.
Absolutely. I think basically by having this dissociative experience, you can reflect more. Right. And you can, like you said, looking back at you is kind of like you just kind of see how you are. And if you're just getting high, right, you're not going to remember that. So,
and also, right, the intention is very specific. Usually we talk about limiting beliefs, like what belief the person has about themselves that limits them and where did that come from. So a lot of the patients I see are, their default is to think I'm not lovable, I'm not good enough, or I'm weak. And so what we're doing is we're kind of setting them up with a visualization and a specific intention going into it. I'm willing to believe that I am lovable, so we're really giving them the positive version of that. And sometimes the intention is very aligned with their session, and other times other things come up, and, we're trying to make sense of it. And it's really just an interesting process to reach these non-ordinary states of consciousness.
Absolutely. I love this approach we dabble in the functional medicine, and it's all about finding the root cause. And it sounds like this is amazing, getting down to the root.
Are there any contraindications to ketamine therapy, or are there people who are not candidates for ketamine therapy?
Yeah, so I would say someone who has schizophrenia, someone who's had a history or episode of psychosis, bipolar with mania, and uncontrolled high blood pressure would be the main contraindications.
Okay. And what about, is there any downtime or any things that people need to be aware of before, things to avoid or do before or after a treatment?
That's a good question. So before, we ask them not to eat, because sometimes the ketamine makes them nauseous, and we don't want them to vomit, obviously, but we always give them Zofran or a medication to prevent the nausea. But if you think about it, you're basically going on this journey, and then your brain has to recalibrate back to where you are in reality. So sometimes people feel a little dizzy or nauseous after. So we tell them not to eat. They obviously need a ride home because they're not able to respond in the way that they want. They really feel very relaxed and at peace after. And so we actually tell them not to do anything very stressful for a few hours after. We want them to kind of keep that positive. And also their brain is in this critical state for neuroplasticity. So we want them to be with positive people and not just throw themselves into something stressful. Like I had a patient who would be, her stressor was at home. And so every time she would come for ketamine, it would be a great session, but then she was just going home to really what was creating a lot of her trauma. So that happens often, which is really why it's important to really know their social system and who is supporting them. That's pretty much it. I mean, we don't want them to be on stimulants. We don't want them to drink alcohol before. Certain medications may blunt the effects of ketamine, so we look into what medications they're on.
Like benzodiazepines?
Yeah, benzos, Lamictal, some of the antipsychotics can. And people worry about that, but at the same time, they have no idea what dissociation feels like. So I usually tell them, if you need this medicine, you can take it, and we'll see how you do on the first session. And then usually they realize that's a significant dissociation, that's not anything that they need to stop a medication to try to get a higher dissociation for.
Okay. So you can adapt with your dosing, basically.
Right.
And how long can people continue therapy?
Well, so ketamine's really done a few sessions in a few weeks, and then we follow up with them and try to see if they need to continue with maintenance. I think that the more work the person does and the more understanding they have of their past and of their lifestyle and having good social support, they're not needing as many sessions. But oftentimes at 3 months, we'll check in with them and see if they need a booster, or even at 6 months. A lot of patients do really well, and then something may happen in their life that may cause a trigger, that may cause them to, start to regress a little bit, and then they'll come back. So usually we do like dose discovery. We figure out what's the best dose for them, what worked best, so that if they need to come back for 1 or 2 sessions, but usually they're also working with a coach or therapist even at that time.
And I know we've talked about, is their personality. So like for somebody who their personality is the pain, and they're mostly focused on the pain, and maybe the pain has caused depression in the past. Is the protocol for pain any different? I guess for the length of how long does that help alleviate their pain? Yeah,
so pain is a little bit more difficult. There's some people that do Monday through Friday, 4-hour infusions, and they just are looking at ketamine as a pain medicine. I do it a little bit differently. I still use IV mainly for the patients who do have chronic pain, but I will usually do it 2 times a week or max 3 times a week, because I like them to have a therapy session in between, and I like them to rest in between. Mm-hmm. Some people think, based on the neuroplasticity, they're giving them the medicine at a higher dose for a longer period of time, and perhaps that's creating change. But I don't think we know a lot about neuroscience now from functional MRIs, but I don't think we're really able to understand these glutamate levels and how that relates to function.
So ketamine is similar to PCP, right? But PCP got such a bad reputation as being a dangerous drug. How are they different, or what's the difference between why one is dangerous and one is not?
Well, I think that ketamine can be dangerous if it's in the wrong context, right? If it's done in the wrong setting. So when we talk about psychedelics, we talk about setting, and dose. Setting is the physical place that they're doing it in. So if someone's doing ketamine recreationally, then it can be very dangerous. They can take a high dose. They can go into something called a K-hole, which is basically when they have such a high dose of ketamine that they are in a very dark place. Sometimes they feel like they've passed away, like they actually think like they're they're dead. And they get a very, and that could be very, very scary for a lot of people. And that's more so in the recreational world, listening to people who have been abusing ketamine or not having any idea how much they're taking and doing it in the wrong setting. In the office, it's completely different. We're looking into specifically what their mindset is, what their intention is. We understand what the dose is. We have this whole therapeutic alliance of myself, the nurse, the therapist, the facilitator. And then the setting is really important so that they feel safe, so that they can totally surrender and let go into the experience, because we don't want them to resist it. If their conscious mind is really in this still state of fight or flight and they're feeling a little bit anxious, then they're not going to be able to get that type of insight that they need. And so the setting has to be very conducive for them to feel comfortable. And I think a lot of what has happened with ketamine is it's become, it was known as a very recreational medication until now, when we have a lot of studies and we have more understanding from using it in the clinic, and we understand the importance of set and setting. And so they have their eyes closed, so there's not external stimuli. They're listening to a very curated playlist that is specific for ketamine, that doesn't have any words, so that they're not directed in any way. And just their ability to feel safe is number one. And so I think that's really kind of the difference between the recreational world and the clinical world.
Is just since it's in a facilitated, treatment therapy, it's less addictive, I'm assuming, obviously in the office, because it has to be administered by somebody.
Right.
But guess clinically, has anybody become addictive and sought it out on the street? I mean, that's how the opioid pandemic happened.
Right. And I actually am really nervous about the future of what's going to happen with people who are abusing ketamine, because it's like cannabis, even, where people look at it like a medicine and then they start to use it and overuse it and then become tolerant to it, and then it doesn't have the effects anymore. With ketamine, again, most people who are doing it do have depression, chronic pain, PTSD, and when they do a ketamine session, they usually say, I don't know why anyone would ever do this in a recreational way, because it may be pleasant, but it's a journey. There's a lot of work that goes into it. Right. So I find, like, in the clinic, it's a different setting that doesn't really make people want to go abuse it, because there's a lot of work involved. And even the dissociation may be very positive, but then they take that session and then it kind of stays in their mind forever. It's a very salient type of memory. And I think that in the wrong person, they may have the potential for abusing any substance. So whether it's ketamine or something else, they'll find a substance that they like. I find that the at-home ketamine model is extremely dangerous, because you're basically sending a dissociative home to someone, hoping that they have a sitter and that they understand the dose. And this is going to create addiction, because people are basically getting access to ketamine outside of the office.
There's some compounding pharmacies that have ketamine available. I've seen that, and I always wondered about the safety of that.
Well, and I do have some chronic pain patients that I was able to wean off opioids using ketamine, and it's just not sustainable since it's not covered by insurance. And so some of those patients, I will write a prescription for ketamine, but I've known them for probably 8 years, right? And they're really using the medication in a prescribed way. And oftentimes I'll give them a lozenge of ketamine, maybe 75 milligrams, 50 milligrams, and they take it every third day. And that's just enough to give them some relief. And then there's some neuroplasticity and some effects that kind of linger on for a few days. And this way, we're not building tolerance and also creating addiction, because they're not taking it on a daily basis.
Well, and I'm sure because you've already been working with them for so long, they know exactly how to do it and put themselves in that environment, ideally.
Right. And
the proper environment.
Right. I mean, I think the goal really is to get ketamine covered by insurance with a specific protocol. And, I'm actually working with University of Florida on a study looking at a specific protocol for treatment-resistant depression, how many sessions we would need in the course of a year to show that after 1 year, their depression is relieved. Because really the studies that we have, it's acute rapid antidepressant. It helps with suicidal ideations. People feel better at 3 months, maybe at 6 months, but we don't really have any longitudinal evidence past that.
Well, I love how you mentioned before about other things that there's studies going on with fibromyalgia, or even the what used to be called formerly RSD, or the complex regional pain syndrome, because I feel like both of those are conditions that people they feel, and a lot of physicians out there don't take them seriously. If they can't pinpoint to where their pain is or what their pain is caused by, then it shouldn't exist.
Right.
And so I think this is a great treatment option for people who have pain that is not caused by a physiological aspect.
Right. Yeah, so usually there's an amplification in the nervous system where there's too much signals coming from the body to the brain, and there's not enough breaks, stopping it. So there's the descending inhibitory pathways aren't working well. That's like the serotonin, norepinephrine type of neurotransmitters that we would use like Cymbalta for example. So there's all these different pathways in the brain and the nervous system where we can use different medications. And that's why a lot of the antidepressants are also used for chronic pain and even musculoskeletal pain. However, I don't really think they work that well. So conditions like fibromyalgia, a lot of them, I had a patient actually yesterday who has fibromyalgia and chronic fatigue. And after doing ketamine sessions, we realized how much of her personality was really defined by her pain and suffering, and how she just became someone who suffered, and that was like who she became. And so she was
a victim,
right,
basically.
Exactly. And so like her whole identity was now, I'm someone who can't do this because it's going to cause more pain. And we really just had to reprocess that pain. And a lot of times I teach the patients that pain is just a sensation in the body, and there's an emotional experience attached with it. Oftentimes the emotional experience is a past trauma or just anxiety, where they feel the fire alarm is constantly going off and there's no real fire. So we're really reprocessing the sensations in the body to understand it's just a sensation. You can just track it and then do different breath works and different types of mindfulness techniques to kind of reprocess the sensation. And really underlying it is the anxiety, really understanding where the anxiety came from and how the anxiety lives in the nervous system. Even things like RSD, or complex regional pain syndrome, it's a sympathetic chronic pain syndrome, meaning the sympathetic nervous system is in fight or flight, showing you it has pain, but also there's a component of anxiety there as well. So it's really treating both. You can't just, and that's why I don't just use ketamine infusions for chronic pain, because they still need to relate to their pain. They need to also, a lot of them have shame that they've lived so long with pain and really never address the root of it. So there's other different qualities that attribute to these sensations in the body that people call pain.
And people don't understand, like, these chronic pain medicines, they're just Band-Aids, and they're creating more and more problems.
And especially with opioids. I mean,
yes,
it's basically giving yourself a medicine to stop your own production of your endorphins, which means you can't really enjoy natural pleasures. We teach people to just savor natural things, go out in nature and enjoy what there is, without needing to medicate and without needing to alter their mind.
And so I've heard that this is also known as a kind of a chemical meditation. Mm-hmm. I've heard that before, and I thought that was really interesting. And so is that something that you also recommend that they kind of work on their own? Like, they could also just do some mindfulness and floor meditations a few times a week?
We give them like a homework kind of like journal that has different things to do each week and how to optimize your lifestyle. And we give them all the